Asherman syndrome, also called intrauterine adhesions, is a pathological condition where fibrous scar tissue forms within the endometrial cavity. The scarring typically creates bands or sheets that can tether opposite walls of the uterus together. This process frequently follows procedures that denude the basal layer of the endometrium, most commonly dilation and curettage performed after miscarriage, postpartum hemorrhage, or elective termination. The loss of the regenerative basal layer impairs normal ray epithelialization, allowing fibroblasts to deposit collagen unchecked. Clinically, the syndrome is significant because the adhesions can obstruct the uterine cavity, leading to hypomenorrhea or amenorrhea, chronic pelvic pain, infertility, and recurrent pregnancy loss. The eponym derives from Dr. Henry Asherman, who first described the condition in the 1940s after observing women with absent menses following uterine instrumentation. The majority of intrauterine adhesions arise from direct trauma to the endometrial lining. The most common iatrogenic triggers include: Number 1, dilation and curettage D and C after miscarriage delivery or elective termination, particularly when performed without visual guidance. Studies report that 1 to 4% of women undergoing a single D and C develop adhesions, with the risk climbing to greater than 10% after multiple procedures. Number 2, hysteroscopic surgery for submucosal, fibroids polyps or septum resection, if aggressive resection removes the basal layer. Number 3, cesarean section complications such as uterine incision, extending into the endometrium or retained placental fragments. Number 4, postpartum hemorrhage requiring aggressive uterine curettage or uterine tamponade. Number 5, infectious etiologies like severe endometritis or genital tuberculosis, where chronic inflammation promotes fibrotic healing. Number 6, rare congenital anomalies, for example Mullerian agenesis, with uterine remnants that predispose to synecdoche formation. Number 7, environmental and lifestyle factors, smoking and poor nutritional status, delay epithelial regeneration, increasing scar formation. Practical example, a 28-year-old woman who undergoes 2D and CS for retained products, after a miscarriage develops hypomenstruation hysteroscopy later, reveals multiple thin, filmy adhesions, confirming an iatrogenic etiology. When the endometrium is injured, the normal wound healing cascade is activated. Hemostasis, blood clot formation releases platelet-derived growth factor, PDGF. Inflammation, neutrophils and macrophages infiltrate, secreting cytokines IL-1, TNF-alpha that recruit fibroblasts. Proliferation, fibroblasts differentiate into myofibroblasts, synthesizing extracellular matrix components, chiefly type 3 collagen, later remodeled into type 1. Remodeling, matrix metalloproteinases MMP2, MMP9 normally balance collagen deposition. But in the uterus, the thin myometrial wall and limited vascular supply impair this balance, especially when the basal layer is lost. The result is the formation of a fibrous sheet that adheres opposing uterine walls. Hormonal milieu influences this process. Low estrogen states after D and C reduce endometrial regeneration, while excessive prostaglandins can exacerbate inflammation. Additionally, hypoxia within the sealed cavity promotes fibroblast activation through HIF-1 alpha signaling. Practically, a woman with prolonged amenorrhea after D and C shows on hysteroscopy a dense opaque band across the cavity, an illustration of uncontrolled fibroproliferation overriding normal ray epithelialization. Accurate prevalence data are limited because many cases are asymptomatic or go undiagnosed. Current estimates suggest incidence after D and C, 1 to 4% after a single procedure, rising to 10 to 20% after 2 or more. Overall prevalence in reproductive age women, 20 to 40 years, is thought to be under 5% in high-resource settings, but may be higher in low- and middle-income countries where postpartum infections and unmonitored curettage are common. Geographic variation: higher rates are reported in sub-Saharan Africa and Southeast Asia, correlating with higher rates of postpartum sepsis and limited access to hysteroscopic guidance. Age distribution: peak incidence aligns with the reproductive window because this is when uterine instrumentation is most frequent. Older women are less likely to develop clinically significant adhesions due to decreased uterine activity and lower fertility expectations. Epidemiologic studies often rely on hysteroscopic screening of women presenting with infertility or abnormal bleeding, which may overrepresent severe disease. The clinical presentation ranges from subtle to severe. Menstrual abnormalities: the hallmark is hypomenorrhea, light bleeding, progressing to amenorrhea, complete cessation. The degree of flow reduction correlates with the extent of cavity obstruction. Pelvic discomfort: some women report dysmenorrhea, chronic lower abdominal or pelvic pain, especially when adhesions restrict uterine expansion. Infertility: primary or secondary infertility is common, as adhesions impede sperm transport, embryo implantation, and normal endometrial receptivity. Recurrent pregnancy loss: embryos may fail to implant properly or be expelled prematurely due to a restricted cavity. Incidental discovery: Asherman syndrome may be identified during evaluation for unrelated conditions, for example, hysterosalpingography for tubal assessment, or during routine hysteroscopy. A 32-year-old woman reports that after a dilation and curettage for retained placenta, she has not had a period for 6 months, and attempts at conception have been unsuccessful for a year. This constellation prompts further investigation for intrauterine adhesions. Diagnosis proceeds in a stepwise manner. Clinical suspicion based on history uterine instrumentation and symptoms amenorrhea and infertility. Transvaginal ultrasound, TVUS, may reveal a reduced endometrial thickness, irregular cavity contour, or a fluid-filled cavity suggesting obstruction, but sensitivity is modest. Hysterosalpingography, HSG, contrast outlines the uterine cavity. Filling defects or complete non-opacification raise suspicion for adhesions. Saline-infused sonohysterography, SIS, real-time visualization of the cavity after saline injection, can delineate thin, filmy adhesions. Diagnostic hysteroscopy, the gold standard, a 5mm telescope is introduced transcervically, allowing direct visualization of the uterine interior. Adhesions appear as grayish fibrous bands. Their location, density, and mobility are assessed. Importantly, hysteroscopy also provides the opportunity for immediate therapeutic adhesiolysis. Adjunctive imaging, MRI, is rarely needed but may be employed in complex cases to assess myometrial involvement. Practical workflow: a woman with amenorrhea undergoes TVUS, inconclusive, followed by HSG, shows a partial filling defect. SIS confirms a thin band at the fundus, and definitive diagnosis is made with hysteroscopy, where multiple filmy adhesions are identified and subsequently lysed. Adhesions are categorized primarily by extent, depth, and location, which guide therapeutic aggressiveness and prognosis. The most widely used system is the American Fertility Society classification. Points are allocated for extent of cavity involvement, percentage of surface area, mild less than 25%, moderate 25 to 75%, severe greater than 75%. Depth of adhesion: filmy thin, easily separable versus dense fibrotic, vascularized. Location: fundal, tubal ostia, isthmic, or cervical. The total score stratifies patients into 4 grades. Grade 1 mild, score 1 to 4. Thin filmy bands, minimal obstruction, high likelihood of menstrual restoration after surgery. Grade 2 moderate, score 5 to 8. Partial cavity obliteration, moderate fibrotic bands, variable menstrual improvement. Grade 3 severe, score 9 to 12. Extensive dense adhesions, often with complete cavity obliteration, higher risk of recurrence. Grade 4 extreme, score greater than 12. Near total or total synecdoche, frequently requiring staged surgical approaches. Practical application. A patient with a hysteroscopic finding of dense tissue covering 60% of the uterine surface and involving the tubal ostia would receive a score of 10, classifying her as grade 3, indicating the need for aggressive adhesiolysis and postoperative anti-adhesion measures. Management aims to restore a patent uterine cavity, reestablish normal menstrual flow, and improve fertility. The core steps are: pre-operative preparation. High-dose oral estradiol 2 to 4 milligrams daily for 10 to 14 days before surgery thickens the endometrium, improving visualization and reducing intraoperative bleeding. Broad-spectrum antibiotics, for example, doxycycline, lower infection risk. Hysteroscopic adhesiolysis. Using a 4 to 5 millimeter operative hysteroscope, adhesions are lysed with micro scissors, bipolar electrosurgery, or laser fibers. The goal is to separate walls gently without perforation. In severe cases, a staged approach, multiple procedures may be required. Intrauterine stenting. After lysis, a Foley catheter balloon, silicone stent, or a custom intrauterine device is placed for 5 to 7 days to keep the walls apart while the endometrium regenerates. Post-operative hormonal therapy. Continuous high-dose estrogen 2 to 4 milligrams for 2 to 4 weeks, followed by cyclic progestogen for 10 to 14 days, promotes endometrial regeneration. Some protocols add tamoxifen or selective estrogen receptor modulators to further stimulate growth. Adjunctive anti-adhesion agents. Hyaluronic acid gel or autocross-linked hyaluronan placed intrauterine after surgery has shown reduction in ray adhesion rates 10 to 15% versus 30% without. Follow-up. Repeat hysteroscopy at 4 to 6 weeks assesses for residual or recurrent adhesions. Additional adhesiolysis is performed if needed. Fertility planning. Once the cavity is stable, couples may attempt natural conception. However, many clinicians recommend assisted reproductive technologies ART, such as IVF, to maximize pregnancy rates, especially in grade 3/4 cases. Example: a 30-year-old woman with grade 2 adhesions undergoes hysteroscopic lysis, placement of a Foley balloon, and a 30-day estradiol regimen. At 6-week hysteroscopic checkup, only minimal filmy bands remain. She proceeds to IVF and conceives a singleton pregnancy. Preventive strategies focus on minimizing endometrial trauma and promoting optimal healing when instrumentation is unavoidable. Avoid unnecessary uterine curettage. Use expectant management for retained products when safe, or employ medical management misoprostol instead of mechanical removal. Hysteroscopic guidance. Whenever tissue removal is required, employ hysteroscopic visualization to limit depth of resection and preserve the basal layer. Prophylactic hormonal therapy. Administer short-course, high-dose estrogen 2 milligrams estradiol immediately after D and C or hysteroscopic surgery to accelerate ray epithelialization. Prompt treatment of postpartum hemorrhage. Early uterotonics and minimally invasive evacuation techniques reduce the need for aggressive curettage. Infection control. Perioperative antibiotics and strict aseptic technique lower the risk of endometritis, a known promoter of fibrosis. Patient education. Inform women about the potential risks of repeated uterine procedures and obtain explicit informed consent, encouraging shared decision-making. Smoking cessation and nutritional support. Counsel patients on quitting tobacco and ensuring adequate intake of vitamins A, C, and zinc, which are essential for tissue repair. Implementation example. A tertiary obstetrics unit adopts a protocol where every D&C is preceded by a brief counseling session, a 48-hour estrogen regimen, and a postoperative SIS to confirm cavity integrity, resulting in a 40% reduction in Asherman-related admissions over 2 years. Prognosis hinges on adhesion severity, completeness of surgical removal, and postoperative care. Restoration of menstruation occurs in 70 to 90% of women after successful adhesiolysis, especially for mild and moderate grades. Pregnancy achievement varies. Natural conception rates are 30 to 45% for grade 1 to 2, whereas IVF-mediated conception reaches 55 to 65% across all grades when the cavity is cleared. Ray adhesion risk is 10 to 30% overall, but climbs to over 50% in severe grade 3 to 4 cases. Use of intrauterine stents and anti-adhesion gels lowers this risk. Obstetric outcomes. Subsequent pregnancies carry higher odds of placenta accreta spectrum, preterm delivery, and miscarriage, particularly if extensive basal layer loss occurred. Long-term fertility. Women with residual dense adhesions may experience diminished ovarian reserve secondary to repeated hormonal therapy, although direct causality is unclear. Quality of life. Restoration of normal menses relieves psychological distress and improves sexual health. Clinical vignette. After a second hysteroscopic adhesiolysis and a 6-week course of estradiol, a woman with prior grade 3 adhesions regains regular 28-day cycles and, after IVF, delivers a healthy-term infant. Follow-up at 12 months shows no recurrence of synecdoche on hysteroscopy. Emerging investigations aim to enhance endometrial regeneration and prevent scar formation. Stem cell therapy, autologous bone marrow-derived mesenchymal stem cells, BMSCS, or menstrual blood-derived stem cells are injected intrauterine after adhesiolysis. Early phase 2 trials report improved endometrial thickness, average increase of 5 millimeters, and higher pregnancy rates, up to 70% in severe cases. Platelet-rich plasma, PRP, PRP-rich in growth factors, PDGF, TGF-beta, VEGF, is applied to the denuded cavity post-surgery. Randomized studies show reduced ray adhesion rates, 12% versus 28% control, and faster restoration of normal menstruation. Anti-adhesion barriers, novel biodegradable hyaluronic acid gels, cross-linked with polyethylene glycol, provide longer residence time, 48 to 72 hours, compared with traditional gels, offering superior separation of uterine walls. Molecular biomarkers, serum and uterine fluid levels of matrix metalloproteinase 9 and tissue inhibitor of metalloproteinases 1, TIMP1, correlate with adhesion severity. A predictive algorithm is under validation for early identification of high-risk patients. Robotic-assisted hysteroscopy, integration of robotic articulation improves precision in dense adhesions, reducing perforation risk. Pilot data suggest shorter operative times and higher complete lysis rates. Hormonal regimen optimization. Comparative trials of high-dose estradiol versus combined estrogen tamoxifen protocols are evaluating which regimen yields maximal endometrial proliferation with minimal side effects. These advances collectively point toward a future where Asherman syndrome may be prevented or reversed with minimally invasive, biologically driven therapies rather than solely mechanical lysis.